So in this video we will talk about cerebral palsy from edition 10th of Ghai, page number 578. Cerebral palsy refers to permanent, non-progressive and occasionally evolving disorder of the tone, movement or posture caused by insult to the developing brain. Okay, so this is a very complex definition. What is happening? There is insult to the developing brain. This is leading to what? A permanent, non-progressive and occasionally evolving disorder. Okay, and it is a disorder of what? Disorder of tone, movement or posture. So there is an insult to the developing brain which leads to progressive, non-progressive, permanent and occasionally evolving disorder of tone, movement and posture or posture. Okay. It is the most common chronic motor disability in the childhood, affecting 2 to 3 infants per 1000 live births. While the perinatal asphyxia was considered as the most common cause, it accounts for less than 10% of the cases. Various causes are listed in the table that we will read about. Now talking about the clinical features, the most common presentation is with the developmental delay. Okay, how will the children with the CP present with? Mostly they will presentation is with the developmental delay. Physical findings are persistence of the neonatal reflexes. These are the causes of cerebral palsy that we will read about. Okay, so there will be persistence of neonatal reflexes that we can see in the children with CP. There will be increased tone, there will be fisting with the cortical thumb, scissoring of the legs to walking, abnormal posture and gait, abnormal movements or hyperreflexia. Common comorbidities include the intellectual disability will be present. There can be microcephaly, seizures, behavioral problems, difficulty in speech, language, swallowing or feeding, blindness, deafness, squint, malnutrition, sleep disturbances and excessive drooling. Contractures may develop that are initially dynamic and later fixed. Now let's read about the causes of cerebral palsy. So first we will talk about the genetic and the prenatal factors, then about the perinatal factors and about the postnatal factors. In the genetic or the prenatal factors, there can be genetic disorder, inborn error of metabolism, structural malformation of the nervous system, congenital or the intrauterine infections, teratogens, maternal or obstetric complications. These were all the prenatal, before birth causes of cerebral palsy. Fine. So there are some mother related and also some mother related mostly causes are these maternal and obstetric complication, any teratogen intake or yeah, that's it. And these are child related only, like genetic disorder, inborn error of metabolism, structural malformation of the nervous system, and congenital or intrauterine infection is also mother related. Okay, now in the perinatal causes, there can be birth asphyxia, prematurity, low birth weight, birth trauma, neonatal infection, neonatal seizures, neonatal hypoglycemia, intracranial hemorrhage, and neonatal hyperbilirubinemia. These are the perinatal causes that can cause CP. Birth asphyxia is just asphyxia during the birth, prematurity if born before the proper weeks of 9 months, and the low birth weight is also cause of CP. Birth trauma, we all know. Neonatal infection and neonatal seizures are also cause of CP. Neonatal hypoglycemia, even these three factors, infection, seizures and hypoglycemia, are also perinatal causes. And then comes the intracranial hemorrhage and neonatal hyperbilirubinemia. Okay. So this was all about perinatal causes. Now coming to the postnatal causes. Postnatal causes can be infections of the central nervous system, any hypoxia, trauma, drugs, toxins and metabolic disorders. These are the postnatal causes. Now talking about the classification. Cerebral palsy is classified topographically as quadriplegic, hemiplegic, monoplegic or diplegic, and physiologically as, so there are two types of classification of CP: topographical classification and physiologically also it is classified. So if we talk about the topographical classification, it is basically based on the number of limbs involved. Quadriplegia, all four limbs will be involved. Hemiplegia, half side of the body will be involved. Monoplegia, only one limb. And diplegia, both the limbs, either upper or lower. Physiologically, there can be spasticity, dyskinetic, ataxic, or mixed. Then also we will read in the table. Spastic palsy may be quadriplegic, diplegic, or hemiplegic, while dyskinetic palsy may be chorioathetoid or dystonic. So again, spastic type is again divided into these quadriplegic, diplegic, or hemiplegic, and dyskinetic palsy again is divided into chorioathetoid or dystonic. Starting with the spastic quadriplegia. Spastic quadriplegia is the most common type of cerebral palsy. Fine. This CP, spastic quadriplegia, is the most common type of CP in India. It is often caused by perinatal asphyxia or neonatal illness. Okay. Common comorbidities are intellectual disability, seizures, pseudobulbar palsy, microcephaly, squint or visual disturbances, speech abnormalities and deformities. Neuroimaging may show cystic encephalomalacia. On neuroimaging, what will be seen? There will be cystic encephalomalacia. Okay. Moving ahead to read about the spastic diplegia. Is the second most common type and is linked to prematurity. Spastic diplegia, it is the second most common type and it is linked to what? It is the second most common type and linked to prematurity. Okay. If either upper or lower limbs are involved in a CP child, no, then think of take a proper history of prematurity. Intellect is often preserved. Okay, in diplegia 1, the intellect is often preserved. Neuroimaging shows periventricular leukomalacia. This is important. So on neuroimaging, periventricular leukomalacia will be seen. Here, cystic encephalomalacia was seen. Now coming to the spastic hemiplegic palsy. Usually results from a vascular insult or perinatal stroke. Okay, what happens is there is either a vascular insult or perinatal stroke. Early hand preference is the clue. In spastic hemiplegia 1, what is seen? Early hand preference is the clue. Neuroimaging usually reveals a focal changes or a proencephalic cyst. So what will be seen in neuroimaging? Focal changes or it's porencephalic cyst. These children are usually mobile. These hemiplegic palsy ones are usually mobile. They may have preserved or impaired intellect. Now coming to dyskinetic or the extrapyramidal palsy. This may result from asphyxia or kernicterus, rigidity, dystonia, dyskinesia, and drooling are prominent while intellect is relatively preserved. Radiology may indicate abnormalities in the basal ganglia or thalamus. So in dyskinetic type, there is rigidity, dystonia, and dyskinesia. And drooling, they are the prominent features, while intellect is relatively preserved. And radiology may indicate abnormalities in the basal ganglia or thalamus. Fine. This will be seen in this dyskinetic or the extrapyramidal palsy. On radiology, what will be seen? Abnormalities in the basal ganglia or thalamus. Now there is also something called ataxic palsy. Ataxic palsy is caused by the cerebellar malformations and is associated with the other cerebellar signs also. And then at the last, there is something called mixed cerebral palsy. Refers to the presentation including both the spastic and the extrapyramidal features. Okay, now coming to the evaluation. A detailed history is taken to detect the various manifestations and antecedent events. Physical and the neurological examination should include assessment of development and evaluation for dysmorphism and neurocutaneous markers. So in CP child, no, we have to look for dysmorphism and the neurocutaneous markers. Spasticity is classified using the tools such as the gross motor function classification system and modified Ashworth scale. In management requires a multidisciplinary inputs from the pediatrician, occupational therapist, physiotherapist, clinical psychologist, orthopedic surgeon, speech therapist, ophthalmologist, ENT, social worker, and the special educator. Generalized spasticity is managed by physiotherapy and drugs such as the diazepam, baclofen, tenazidine, or dantrolene. So these drugs can be used for generalized spasticity, drugs such as diazepam, baclofen, tenazidine, dantrolene. Intrathecal baclofen therapy uses an implantable pump to deliver the muscle relaxant drug baclofen into the cerebrospinal fluid. Dystonia is managed with trihexyphenidyl levodopa or botulinum toxin injections. Localized spasticity can be effectively treated with the injection of botulinum A toxin. Some patients may require tendon release or the tendon lengthening. Orthotic devices such as the braces, splints, wedges, and special shears help to compensate for the muscle imbalance and increase the independent mobility. Fine. So this was all about CP, and before ending this video, let's read about the stable types of cerebral palsy and their characteristics. So in spastic quadriplegia, there is, what is the antecedent cause? It is perinatal asphyxia. In spastic quadriplegia, intellectual disability is present, seizures, microcephaly, pseudobulbar palsy, squint visual disturbance, speech abnormalities. All this will be present, and on radiology there will be cystic encephalomalacia. Spastic diaplegia seen in prematurity, intellect often preserved, toe walking is seen, periventricular leukomalacia is seen in the spastic diaplegia one. In spastic hemiplegia, there is an avascular event, preserved or impaired intellect, and usually ambulatory. Porencephaly will be seen. In extrapyramidal one, asphyxia and the connectedness are the cause. There will be rigidity, dystonia, dyskinesia, and drooling are the prominent. Intellect is usually preserved, and basal ganglia abnormalities will be seen. In ataxic, cerebellar malformation, cerebellar signs will be seen in cerebellar malformations. Mixed asphyxia, both the spastic and the dystonic features. Okay. In mixed one, what will be seen? There will be asphyxia in both the spastic and dystonic features. Now let's revise everything in short. Cerebral palsy, there it is due to insult to the developing brain, which is a permanent, non-progressive and occasionally evolving disorder of tone, movement or posture. Presentation, we are just going to read the highlighted points. Okay, just follow through. Presentation is with the developmental delay and persistence. On finding, there will be persistence of the neonatal reflexes. There will be increased tone, fisting of the cortical thumb and scissoring and toe walking, abnormal posture and gait, abnormalities of the movement or hyperreflexia. Common comorbidities include the intellectual disability, microcephaly, seizures, behavioral problems, difficulty in speech, language, swallowing or feeding, blindness, deafness, squint, malnutrition, sleep disturbance and excessive drooling. So on classification, it was classified on the two bases, topographically and physiologically. Topographically, it can be quadriplegic, hemiplegic, monoplegic, diplegic. Physiologically, it can be spastic, dyskinetic, ataxic or mixed. Okay, now spastic type is again quadriplegic, diplegic or hemiplegic, and the dyskinetic type may be a chorioathetoid or dystonic. In spastic, most common type, it is the most common type of CP in India, and it is caused by the perinatal asphyxia or neonatal illness, and neuroimaging we already saw, cystic encephalomalacia. Spastic diaplegia, second most common type, linked with prematurity, intellect may be preserved, and on neuroimaging there will be periventricular leukomalacia. Okay. Spastic hemiplegia due to vascular insult or perinatal stroke. Early hand preference will be seen in this hemiplegic palsy, and there will be, on neuroimaging there will be focal changes or a porencephalic cyst. Dyskinetic type may result from asphyxia or kernicterus, and there will be rigidity, dystonia, dyskinesia and drooling and are prominent. Intellect may be relatively preserved, and on radiology there will be abnormalities in the basal ganglia or thalamus. Then there is ataxic type. There will be cerebellar malformation and cerebellar signs will be present. In mixed type, there is presentation including both the spastic and the extrapyramidal features. While evaluation, we should evaluate also about the dysmorphism and the neurocutaneous markers. Now, in management, it is a multidisciplinary inputs from various departments, but the common drug that we use, generalized spasticity, can be we can manage it by physiotherapy and drugs such as the diazepam, baclofen, tenazidine, and dantrolene. And dystonia can be managed with the trihexyphenidyl, levodopa, or botulinum toxin injections. Thank you.